I heard that the Orbita trial was probably the most poorly received trial ever to hit Germany, and that in Germany it was particularly not favoured and people really didn't like the results, even more so in the US. So today, hopefully, is your opportunity to ask me as many questions as you like. Tell me how much you hate the trial and what you would have done differently if you were me. You are welcome to challenge me as much as you'd like. I'll talk to you obviously about Orbita. I'll try and put Orbita in context now that we have the results of ischemia, and also talk to you about our new trial, Orbita 2. So when we were designing Orbita, we were looking at patients like this, patients who had presented to our outpatient clinics with stable coronary artery symptoms. They'd come with angina, exertional in most cases, or angina equivalent symptoms, and then they'd come to our cath labs and have stenoses like these on their angiograms. And the question we asked was, why do we treat these patients? Do we really have the evidence that we know what we're doing and what benefit we may have for our patients? And when we think of that question, we need to think of the treatment goals in stable angina. So I would say that there are three main treatment goals. The first is relief of angina, improvement of quality of life, and hopefully returning our patients back to the quality of life that they had before. And in fact, that first goal was actually the primary goal of angioplasty, and the development of angioplasty was primarily for the relief of angina. In time, because we're interventional cardiologists, we believed we could do a lot more than that we could prevent cardiovascular death and potentially even prevent MI, LV dysfunction, and CCF, so the sequelae of stable coronary artery disease. We believed as interventional cardiologists that by potentially preventing stable disease from turning itself into acute coronary syndrome in the future, we could prevent cardiovascular death and MI with our stents. Now, obviously, we've seen lots of data that has shown us that potentially that's not the case. This started with lots of smaller trials, but really the impact was greatest when the COURAGE trial came out and showed us that there was no difference in death or MI in patients with stable coronary artery disease if they had angioplasty versus medical therapy. And I think we can all remember the fallout from COURAGE, the many limitations that were said to be an issue with the trial, and the reason people kind of ignored the results. We then had the results from FRAME 2, and of course, as interventional cardiologists, we were much happier with those results. We saw that there was a real difference in the primary endpoint between the angioplasty arm and the medical therapy arm, but actually this was driven primarily not by death or MI, but by urgent revascularization in patients who had been told that they had significant coronary artery lesions, and in physicians who also knew that their patients had significant FFRs in the context of stable coronary artery disease. And I would argue that those urgent revascularizations were really driven by the fact that this trial was unblinded. In fact, when we looked at this a bit more clearly, and we've published on this subsequently, we looked at the impact that unblinding might have had on FAME 2. And what you can see is those urgent revascularization events were primarily driven by non-ECG, non-troponin positive, symptom-only presentations. And in fact, when you look at this even a bit more clearly, if you look at the PCI arm versus the medical therapy arm, you see the impact of unblinding just in their own results from that primary paper. You see that in the angioplasty arm, when you have very few urgent revascularization events in that symptom-only class, where they have no ECG changes, no troponin-positive events. But in the medical therapy arm, as soon as they left the cath lab and were told that they had not been stented, you can see how many of them presented with these symptom-only events. And you can imagine what happened. The patient knows that they have a lesion that's positive. The physician knows that they've left a tight lesion alone. That patient comes back to them in clinic a week or two later telling them they have chest pain, and of course they come back in for an urgent revascularization because you're scared they're about to have a myocardial infarction. And now, 2 weeks on from the primary output come results from ischemia, we have even more evidence that there really isn't the data out there that intervening on patients with even moderate or severe ischemia really changes their outcome in terms of cardiovascular death, MI, or even hospitalization for unstable angina and other events. Now, there's been lots of discussion about this trial and what it might mean for us, but the one thing I think we need to remember is we've done a trial of over 5,000 patients in 38 countries in all over the world. And while we might say this trial is irrelevant to our practice, we must start to admit that there is a very, very low chance that we change outcomes in these patients in terms of death, MI, or hard endpoints. In terms of the very major secondary endpoints, of course, that was cardiovascular death or MI, and we saw no difference between the groups in this large study. So I would argue that in terms of our treatment goals for stable angina, we have really no evidence that we prevent cardiovascular death or that we prevent MI, LV dysfunction, or CCF in the long term in these stable patients. And what we still have is the potential to relieve their angina. The question is, how do we test for this in a clinical trial? Well, when we look back at the previous data that we have, we can see unblinded data of the efficacy of angioplasty on exercise time. And this is a trial that was done way back in the 90s, looking at plain old balloon angioplasty and comparing that to medical therapy. And what they saw was a 96-second improvement in exercise time in patients with single vessel stable coronary artery disease. So we know that unblinded angioplasty certainly seems to make our patients exercise more. In addition, from the COURAGE trial, we knew from the very outset of the primary paper being published that more patients were likely to say that they were free of angina in the angioplasty arm versus the medical therapy arm. But what we saw was that that effect attenuated over time. And the question is that because there was lots of crossover between the arms, or could it have been because there might have been some placebo component that wore off over time? Now, from ischemia, we've also seen that there seems to be an unblinded efficacy of angioplasty on symptoms, and that patients certainly say that they feel better in the intervention arm versus the conservative arm. But I would argue that really in order to test symptomatic or subjective endpoints, we need a different trial design. If we think about the trial design I'm proposing, which is a placebo-controlled trial, actually placebo-controlled trials are not new. In stable coronary artery disease in the 1950s, people were, would you believe, ligating the internal mammary artery as a mechanism for reducing angina. And that was a procedure that was being done by our surgeons. And then finally, a placebo-controlled trial was done that showed that there was no difference between people who had the ligation versus people who had just a placebo surgical procedure. So we've known for a while that subjective endpoints, so breathlessness, exercise time, potentially blood pressure, also symptoms such as angina, may well have a component of placebo in terms of their therapy. And so subjective endpoints like that require placebo-controlled trials. We all learnt the lessons from renal denervation, and of course we saw much unblinded data sets that showed us that there was an improvement in blood pressure in unblinded renal denervation, and then the first blinded control trial of renal denervation showed us that actually the effect of the procedure was much smaller than we'd expected. And of course now we've got more data showing us what kind of patients we might actually be able to treat with renal denervation. So we felt that a placebo-controlled trial was necessary in angioplasty in stable coronary artery disease because angioplasty in and of itself is not without risk in the short or long term. Of course, if you're assessing a procedure that has absolutely no risk, such as homeopathy, you might not need a placebo-controlled trial. But why would you want to put a stent into a patient with potential risk if you don't know the benefit? We'd also seen that PCI is not universally successful. I am an interventional cardiologist, and often I will perform a stenting procedure, be absolutely happy with my result, and the patient comes back to clinic telling me they still have chest pain. And the question is why? We know that we have an alternative. We might not like it, but medical therapy exists, and it certainly does have some symptomatic benefits. And also, the efficacy of PCI is a continuum. So we felt that the true efficacy of angioplasty could only be assessed once we knew what the placebo component to our treatment was. Our primary hypothesis was that angioplasty would improve exercise time significantly more than a placebo procedure. We included patients with stable angina who had single vessel angiographically diagnosed coronary artery disease. And all of these patients had come through our normal clinical care pathways and were felt to be suitable for stenting. Here is the study design. We enrolled patients, we took their angina questionnaires and asked them about their CCS class. We then entered them into a very intensive medical optimization phase where they had phone calls 2 to 3 times a week, basically introducing and up-titrating anti-anginal medications, but also medications for secondary prevention. They then came in for a pre-randomization assessment where they had their questionnaires repeated, they had a stress echo, and also an exercise test. They then came in for the blinded procedure, and this was really the crux of Orbita. In that procedure, they wore headphones and were listening to music. They had assessment of IFR and FFR, and then they were sedated. And after they had reached a deep level of conscious sedation, we randomized them 1-to-1 to PCI versus placebo. They then came out of the lab, woke up on the ward outside, had no idea what they'd had done, and neither did any of the physicians or the nursing staff outside. During that blinded follow-up phase, they saw no one who knew what intervention they'd had done, and then they came back for a follow-up assessment that was also blinded, in which we repeated all of the assessments that we'd done before. Blinding was obviously absolutely paramount to Orbita. As I said, the patient wore headphones and was listening to music throughout the procedure. They couldn't see the cath lab screens, and they were sedated until they were fast asleep. If they were in the placebo arm, they waited on the table asleep for a minimum of 15 minutes before we took them outside. Both arms were treated with dual antiplatelet therapy, and they all had a standardized handover with the ward team blinded to what they'd had done. And of course, no one had any access to the cath lab reports. They all had the same discharge letter saying that they'd had a coronary angiogram, they may or may not have had angioplasty, and we tell the GPs and the rest of the physicians in 12-week time what we'd done. This was the results of the Orbita trial. So we enrolled 230 patients. 200 patients were randomized to PCI versus placebo. The primary endpoint of the trial was a difference in the change in total exercise time between the two groups. And we were shocked as interventional cardiologists to see that while the PCI arm did improve in terms of their exercise capacity, the placebo arm also improved, and therefore the difference between the two groups was not statistically significant and was much smaller than we'd expected. It was 16.6 seconds versus that 96-second improvement that we'd seen in the equivalent ACME trial. We looked at other metrics, so we found that angioplasty certainly did improve the blood supply to the heart. It improved ischemia as assessed by FFR and IFR. It also improved ischemia as assessed by stress echo versus placebo, and essentially patients in the angioplasty arm had a normalization of their wall motion index score. However, we didn't see a difference in secondary endpoints on the various Seattle Angina questionnaires and the quality of life questionnaires that we did. We saw that really there was no difference between the two groups. So in terms of the results, this was the first placebo-controlled trial of angioplasty in stable angina. It showed that angioplasty was safe and physiologically effective. It also showed that angioplasty improved ischemic burden as assessed by stress echo, but that the effect size of angioplasty on exercise time and symptom relief was far smaller than we'd expected. So of course, you've all seen the post-Orbita fallout, and I'll summarize some of that here. Firstly, our primary publication was published in conjunction with an editorial that was certainly not written by myself or any of the investigators that said that this was the last nail in the coffin for angioplasty in stable angina. And I think many people were most upset with the editorial as opposed to our own paper. And I question sometimes how often people have actually read the primary manuscript as opposed to reading an editorial piece and an opinion piece by non-interventional cardiologists. So as a result, probably of that editorial as opposed to our actual trial, we were suddenly all over the newspapers. I was interviewed by the New York Times, Time Magazine, Wall Street Journal, and I was certainly not expecting that. And of course, since then, you've probably all read many, many, many different editorials that come out probably every month about Orbita and are still continuing to come out. And each time I do a talk, I update this slide, and there's another editorial that I haven't read. But I must say, those editorials say many different things. Some of them call to the limitations of the trial, and of course there are some limitations. Others say that this was a brave design and that there's something to be learnt. Often I can tell exactly the conclusion of the editorial based on the editorials themselves, particularly if I start with the conflicts of interest declaration, and I can kind of work backwards from there. So let's tell you what's happened since the primary publication. We've obviously published a bit more. We tried to look in Orbita at which predictors we could see from our patients which might predict the improvement in terms of the endpoints on Orbita that may be different between the two groups. So how could you tease out for whom angioplasty may have the greatest benefit? So we looked at the FFR and IFR. We stratified our patients based on their FFR and IFR results and looked at the relationship with the endpoints in Orbita. And what we found was that the lower the FFR or the IFR, so the more ischemic the patient was on invasive physiology, the higher the likelihood that you would have a placebo-controlled improvement in the stress echo score. So the ischemia on stress echo would improve more with the PCI arm than the placebo arm in patients with a lower FFR or IFR. So that was interesting. However, what we didn't see was an impact on some of the other endpoints. We found that 1 in 5 more patients were free of angina in the angioplasty arm. But what we didn't see was an impact on FFR and IFR on these endpoints. So the lower the FFR and the lower the IFR, there was no change in terms of, or no difference between placebo or PCI in terms of the likelihood of you becoming free from angina. There was also no impact on the primary endpoint in terms of exercise time, and this was of course important. We have subsequently published very recently the stratification of the Orbita endpoint results based on the stress echo score. And here what we saw was that the higher the stress echo score, so the more segments that were ischemic, the lower the FFR or IFR, and this relationship was very linear, and that was important. We then saw, interestingly, that the higher the stress echo score and the more ischemic the patient was, the more likely you were to be able to improve symptoms of angina on the Seattle Angina Questionnaire with PCI versus placebo. We, however, didn't see an impact of stress echo score on the other endpoints in terms of freedom from angina or on total exercise time, the primary endpoint of the trial. And you might say, why is that? Why are we not quite seeing what we might have expected? So there's probably lots of answers. Some people would say that the trial design could have been different. Some would say that the efficacy of angioplasty truly is smaller than we expected, and we need to start to acknowledge that. And then others might say that the link between ischemia and symptoms is incredibly complex. So in terms of should the trial design have been different, well, you've probably heard lots of limitations stated about the Orbita trial. One limitation that I hear all the time is that it was an incredibly small study. The thing I think people need to remember about the size of the study is the size of the study depends on the endpoint that you're studying. And when looking at a continuous endpoint like exercise time or symptoms, one that you expect to see in practically all of your patients, you really shouldn't need large numbers in order to study that. We're very used to seeing thousands of patients in trials, and that's because we're very used to studying quite rare events, such as death or stent thrombosis or myocardial infarction. In Orbita, we actually very conservatively powered the study. We powered it for a difference in the exercise time of 30 seconds between the two groups, much lower than that 96-second improvement we'd seen in ACME. In practice, our standard deviation was actually wider than we'd predicted, and so we were powered to detect a difference between the two groups of 34 seconds. So at 16.6 seconds, we were very far away from the margin of error. And so, in fact, I think we were not as underpowered as people may say. We had a very similar sample size to ACME, we just didn't see the same results. Some people have said that we should have used ischemia testing prior to entering patients into the trial. Well, in fact, 94% of patients in Orbita had a positive ischemic test. So predominantly these were patients that you would be stenting in your cath labs every day. Now, many have said that the anti-anginal therapy was too good, and I agree. An average of 3 anti-anginal therapies was what we achieved, and that might be impractical or poorly tolerated in the real world. And the reality is that if we give patients lots of anti-anginal therapies, the incremental benefit of the stenting on top is probably smaller than it would be in a patient who doesn't have as much anti-anginal therapy. Others have said that our patients were not symptomatic enough. Well, actually, they were as symptomatic in terms of their exercise times or their symptoms on their questionnaires as in ACME, as in COURAGE, and as in FAME2, where we saw unblinded angina relief and exercise time improvement. Many have said that the follow-up was too short. Again, I would argue that that's really not a limitation. Imagine yourself in the cath lab. How quickly would you expect the symptoms in your patient or the exercise time to improve? You don't tell them they need to wait a year until they see their improvement. You expect their improvement to be immediate, or certainly within those first 6 weeks. So actually, the follow-up was chosen to be safe and realistic, and also we expected the PCI effect to be immediate. In terms of the placebo effect, many have said, well, the placebo effect may attenuate over time. But in fact, from the laser myocardial revascularization trials, we see that placebo effect can actually last all the way out to 30 months. And who would want to randomize a patient into a trial where they would be blinded for up to 30 months? So others have said that we could have done the statistical analysis differently, and that's true. The plan had been pre-specified and published and was approved by statisticians ahead of time. We used a paired t-test between the groups, and we could have perhaps used ANCOVA, which we did use in subsequent publications, but in fact it didn't account for any differences between the two groups and did not change the primary outcome result to use a different statistical approach. So what about whether the efficacy of angioplasty is truly small? So I'd like you to think about the efficacy of any therapy, whether it was a drug or an intervention, on a subjective endpoint as represented by this blue box. Our patients just see the efficacy in terms of that blue box. They want to know how much better they will feel. Part of how much better they might feel will be a true physical effect of what we've done in terms of our intervention. But part of it will always be placebo. And for simplicity, I've represented that as 50-50, but of course for different therapies it will be different. Now, in order to improve the size of that blue box, how much better our patient feels, we might do it in two different ways. The first might be to improve the placebo component. So with lots of physician-patient interaction, with reassurance, with basically being a very good doctor, telling that patient that we've fixed the stenosis, we deliver placebo, and we have to acknowledge that that's part of our medical care. And of course, that's what we see in unblinded trials and in unblinded clinical practice. We might also improve the size of that big blue box by improving the physical effect of what we do, by increasing the efficacy of the therapy, by trying to choose patients who might gain the most, so perhaps those with a greater burden of ischemia, and perhaps by not giving them other therapies that would attenuate the results, such as anti-anginal medication in this case. I believe that actually the result lies in the fact that the link between ischemia and symptoms is incredibly complex. We see a patient who comes to us with chest pain, we find a stenosis on their angiogram, and we assume that the two are entirely, tightly and linearly linked. We obviously stent that stenosis, and then the hemodynamics improve, the FFR and IFR get better, and we're happy that we've fixed the stenosis, the pressure gradient has gone away. We will see, and we saw it in Orbita, stress echo improvement or improvement in myocardial motion on any one of our functional tests, and we're happy that all three of those things are linked: the stenosis, the hemodynamic improvement, and also the improvement in terms of myocardial motion. But the assumption we next make is that that will mean that our patient's symptoms improve, and they will tell us that their symptoms improve, and we will record that they improve. But what we're starting to understand is perhaps the link between symptoms and everything else we do is perhaps not as tightly linked as we'd imagined. So what do I believe Orbita means? Well, firstly, I do believe that there's no trial is without limitations, and of course Orbita had some limitations. I also believe that placebo is an incredibly important part of medical care. And I believe that there is a true physical effect of PCI, and that perhaps that effect could be increased if we select the right patients, people perhaps who are more ischemic, people who definitely have chest pain that you think is caused by that stenosis, as opposed to more atypical symptoms. I also believe that the link between ischemia and symptoms is complex, and we shouldn't assume that they will all get better just because we fix the stenosis that we see. And I believe that for some patients, an upfront procedure will always be their first choice. Even when you give them the option to have anti-anginal therapy that may have identical efficacy, they would rather have that procedure. And so you have to have a conversation with your patients. Orbita was always designed not to be the final word in stable coronary artery disease and what we should do in terms of intervention, but was designed to be one piece of an enormous jigsaw puzzle. And of course, we're interventional cardiologists, and there's always room for one more trial. So now we're recruiting for Orbita 2, and I'll tell you a little bit more about it. So I think Orbita 2 is necessary, particularly in this post-ischemia world, because Orbita has shown us that placebo-controlled trials are safe and feasible, that we need to understand much more about angioplasty and stable angina, and that we can build on what we did in the first trial to learn more and to perhaps be able to apply our results to more patients. So in terms of Orbita 2, we have a population that's much larger. So our patients now go into a symptom assessment phase, and in that first 2 weeks, if they're asymptomatic, they drop out of the trial. We recruit all patients with single and multi-vessel disease, but not left main stenosis or CTO. All patients have to have demonstration of ischemia on a non-invasive or invasive test, but we don't use any test as a particular gold standard. They're on real-world anti-anginal therapy, and by that we mean that most patients are on no anti-anginals or minimal anti-anginals, and of course it's a larger trial size, although not thousands of patients, we're aiming for 400 patients. In terms of the intervention, it will be the physiology on this occasion will be unblinded, so the operator will be able to use the physiology in terms of their intervention, and will perform complete revascularization with DES. The control arm is once again a placebo procedure. And in terms of the outcome, we are now using the primary endpoint outcome of a daily symptom frequency on a symptom app. Patients go away with a phone, and essentially every day they tell us what's happened to their symptoms, because we think that that will give us much more granularity than an exercise test and much more information than just a questionnaire about the last 4 weeks of symptoms. There is a slightly longer follow-up period, it's 12 weeks, but it doesn't need to be years long. I believe that our patients should have benefit very quickly, and in fact 6 weeks was long enough. So we'll wait. If any of you got a crystal ball, you can tell me what's going to happen in the future. We've now recruited over 50 patients in 6 centres in the UK. We have 12 centres will be up and running by January, and we'll hopefully have the results in 2 years' time. And so finally, I'm often asked, what is my approach in stable coronary artery disease? Well, basically, my approach has changed. I now spend much more time assessing symptoms thoroughly, because I think I had become very lax in accepting what symptoms would allow me to take a patient to the cath lab. I take some more time and effort on anti-anginal therapy, particularly for those patients who I know a procedure is something that they may not want or may be risky for them. I don't rush to treat what I see. I no longer do angiogram query proceeds, as we call them in the UK. So actually we do diagnostic angiograms, we take people off the table, we think about what we've seen, and then we bring them back for PCI at a later date, regardless of the tightness of that stenosis, because I think ischemia has shown us we have time. I also involve the patient in my decision-making, and I give them much more realistic expectations for PCI. I no longer tell them that this PCI is going to save their life. I tell them this is purely for symptoms, and then we have a discussion about whether or not they want the procedure. And I treat ischemia as a continuum. I do not treat it as a binary cut point. So with an FFR of 0.81, I do nothing, or an FFR of 0.79, I go and stent. I think about it as a gradation. And of course, I know that those patients who have the lowest FFR and IFR may have potentially more benefit from my procedure, and the same with stress echo or any other ischemic test. I consider upfront PCI in those people that I think are most likely to benefit, and those people who I know will want an upfront procedure. And since I'm doing this for symptom relief, I maximise placebo. I now take some time after my stenting to show them my pictures, tell them exactly what improvement I think they're going to have from my procedure, and I counsel them as to what they need to do next with their lifestyle in terms of improving their symptoms going forward. So because lots of people always tell me that Orbita patients were not real-world patients and not the kind of people they normally see, I now go around the world showing photos of some of the Orbita patients. So you can see they were a normal bunch of patients. They were not a group of high elite athletes who had absolutely nothing to benefit. They predominantly were men who were a little bit overweight with white hair. Some of them had walking sticks, and they were really the kind of people you see in clinic. So I don't think that the results should be totally negated, but we're learning more and more about stable coronary artery disease and what we can do in terms of our intervention. And I'll stop there and take your questions.